So today we are going to discuss the contribution of radiology for the diagnosis of gastroesophageal reflux disease. It's a very important topic because it's very frequent, and most of the information that can be provided by radiology cannot be provided by other methods like endoscopy or manometry. So we are going to describe the anatomy of the esophagogastric junction. We are going to review the pathophysiology of the gastroesophageal reflux. We are going to discuss the indications and advantages of imaging exam for the diagnosis of gastroesophageal reflux disease. And we are going to illustrate the radiologic diagnosis, associated findings, and complications. Additionally, I'm going to mention the indications for the surgery or the treatment. Okay, so GI reflux disease, or GI's reflux disease, is the most common inflammatory disease of the esophagus. I think this is maybe more than 0.5% of the US adult population. They have gastroesophageal reflux disease, but the heartburn is experienced, but most of the population at least once a month, okay? And about 20% of the population take some form of non-prescription drugs for reflux. If you go to the supermarket, you are going to be everywhere antacids, okay? And most of them are to treat the reflux, okay? So, and also 20% of the patients that they had endoscopy, they have evidence of gastroesophageal reflux disease. Patients are primarily treated medically with some agents that reduce the acid, but in some cases it's necessary to perform surgery. Okay, so first of all, let's try to discuss the anti-reflux, okay? The mechanism. The most important is the function of the lower esophageal sphincter. The lower esophageal sphincter is a thickening of the circular muscular layer of the lower 5 centimeters of the esophagus, is this area, okay? It's located partially within the chest and partially within the abdomen, okay? Sometimes it includes some oblique fibers from the greater curvature of the sphincter, okay, here, that form the angle of His, that this is also other anti-reflux mechanism toward the lesser curvature. Let's see, okay. So the other anti-reflux mechanism is the hiatus of the diaphragm that is located here, okay? Is surrounded by diaphragmatic crura, okay? And is mostly effective when we have abdominal hypertension in straining conditions. In that moment, there is a contraction of the hiatus, and this helps to prevent a reflux, okay? For example, when we perform sports or something like that. Okay, it works a direct effect compressing the intra-abdominal esophagus, and okay, not only work as an extrinsic compression. Sometimes the contraction can produce some active contraction of the lower esophageal sphincter. They don't know exactly if it's a primary extrinsic compression or also produce some contractions of the lower esophageal sphincter that help to prevent the reflux. Okay, but the esophagus has some protective mechanism, okay? The most important probably is the esophageal clearance, okay? So once the patient have reflux, there is an abrupt distension of the lower esophagus, and these start secondary peristaltic waves, okay? That with the function try to get rid of the reflux back into the stomach. Second one is the neutralization of the reflux. Multiple options we have. Salivary secretions, okay, that neutralize the acidic gastric reflux, bicarbonate secretion by esophageal submucosal glands. Okay? So the defenses of the esophageal mucosa are pre-epithelial. The esophagus has a hydrophobic mucosa, okay? Epithelia, there is resistance to transmucosal ion penetration by tight junctions in the upper cell layer, okay? And finally, there is an extrusion ion, hydrogen ion process, okay, that help to prevent the damage of the mucosa. Okay? So, what is the reason that there is a failure of the lower esophageal sphincter? Well, one of them could be the abnormal location of the sphincter into the chest. For example, when the patient has a hiatal hernia. As you know, hiatal hernia could be the cause, but could be the consequence of the gastroesophageal reflux. If this is due to the cause of the gastroesophageal reflux, the abnormal location of the sphincter works under negative pressure within the chest. And this is one of the reasons of the incompetence of the sphincter. Sometimes there is a congenital short length of the sphincter, could be some primary weakness, okay, of the sphincter muscle, the defective sphincter control mechanism, okay, greater number of sphincter transit relaxation. It means the pressure of the sphincter by manometry is normal, but there are increased number of transitory relaxations that produce the reflux, okay? And sometimes, I will show you later, one case could be a dilated stomach due to gastric outlet obstruction, and this produces an incontinence of the sphincter, okay? So this could be the most common causes of failure of the lower esophageal sphincter. Also, could be an inadequate or slow esophageal clearance of the reflux material due to weak or loss of the esophageal peristaltic contractions, okay? Also could be an impaired reparative capacity of the esophageal mucosa. Okay, so the damage is produced when the integrity of the esophageal mucosa that require a balance, okay, between the injurious forces and defensive forces, okay? So the injurious forces predominate over the defensive forces. So when the balance is impaired, okay, there is an excessive diffusion of hydrogen ions into the mucosa that leads to the cellular acidification, inflammation, and necrosis. So we have now the reflux esophagitis. Okay. So this is when you have a chronic gastroesophageal reflux, okay, it could be fibrosis and strictures of the esophageal lumen, okay? But could be also a replacement of the normal stratified squamous mucosa by metaplastic columnar epithelium, okay? This is what we call Barrett esophagus, that the problem is that there is a high risk of developing adenocarcinoma. That is the reason that this patient has to be followed up closely. Okay, these are the symptoms. I'm not going to discuss them, but this one is the most frequent after meals, okay, and blah, blah, blah. Okay, so how we perform the radiographic evaluation of a patient that we suspect has gastroesophageal reflux? So we perform a biphasic technique, okay, that is a double and single contrast examination of the esophagus. So we perform the double contrast examination technique, usually in upright position, okay, in left posterior oblique position, and also we perform the gastroduodenal phase by double contrast. With single contrast, we evaluate the motility of the esophagus, and we try to identify the gastroesophageal reflux. Additionally, we perform an evaluation of the swallowing, and we try to detect hiatal hernia, even by double or with single contrast. And in some cases that we are looking for subtle esophageal strictures, or we would like to measure the stricture, we use some esophageal pills or tablets, okay? Esophageal barium pills or tablets that we ask the patient to swallow and see if they stop in some areas where we can recognize that there is a stricture. Okay, so the first, when we perform the examination, the first part of the examination is the evaluation of the swallowing, okay? What is important, this phase of oropharyngeal phase on a patient with gastroesophageal reflux is that there are many abnormalities in the swallowing that can be due to long-standing gastroesophageal reflux. One of them is the dysmotilities of the cricopharyngeus. Other abnormalities could be the webs, okay, the formation of webs in the hypopharynx and the esophagus. And if you have a long-standing cricopharyngeal dysmotility, you can have a complication that is the Zenker diverticulum. As you know, Zenker diverticulum is almost always seen on patients with chronic gastroesophageal reflux. So this is part of the examination, and especially is important because the endoscopies cannot evaluate this phase of the examination. And additionally, could be some causes of the symptoms due to abnormalities in the swallowing. So that's the reason this is the first part of the examination, and it's an important part. The second phase of the examination is the upright double contrast examination. For this reason, we request the patient to swallow some crystals, okay? They distend the lumen of the esophagus, and we ask the patient to swallow continuously a high-density barium, and we take pictures of the upper, middle, and especially the lower esophagus. So what do we expect to see here? What we are trying to detect? Well, for example, we can see transient striations we call feline esophagus. Later we will see some examples of all of them. We can see if there is a ring in the esophagogastric junction that is associated with long-standing reflux that is called the Schatzky ring. We try to detect the early phase of the gastroesophageal esophageal inflammation, that is the abnormal mucosal pattern of the esophageal mucosa, thickening of the longitudinal folds, intramural esophageal pseudo-diverticula, and inflammatory reflux polyps. These are usually symptoms of reflux esophagitis. Erosions, ulcerations, strictures, areas of scarring, sacculation, pseudo-diverticula. We try to see if we can detect areas that they are suspicious for Barrett esophagus. And of course, one of the complications of the Barrett esophagus is the adenocarcinoma. So always in the double contrast, we try to evaluate these areas. And finally, with the double contrast phase in upright position, we try to see if there is a shortening of the esophagus that later is going to help us, or is going to help the surgeon in case the patient needs some surgery. Okay? After that, we perform a gastroduodenal phase that is the evaluation of the cardia. Okay? Once we have a patient with dysphagia, we don't know exactly where is the cause of the location of the cause of dysphagia. That is the reason we have to evaluate from the oral cavity and also the cardia and the gastric fundus, okay? That is the reason we always evaluate the gastric fundus in a patient that we suspect gastroesophageal reflux. Some infiltrating tumors of the gastric fundus and the cardia can produce gastroesophageal reflux, but this is just secondary to the tumor, okay? Additionally, in some cases, we have to evaluate the abnormal gastric empty due to gastroparesis of gastric outlet obstruction, because the gastric overdistension could be the cause of the gastroesophageal reflux. After that, we try to perform the esophageal motility phase, okay, with single contrast. For that reason, we usually place the patient in prone position, right anterior oblique position, okay, and we ask the patient to swallow some sips of contrast in order to evaluate the esophageal motility. Why? Because most of the patients, or almost half of the patients with gastroesophageal reflux, they have esophageal motility disorders. So we have to evaluate that, okay? So we evaluate the propagation of the primary wave when the patients swallow, okay? Sometimes the retrograde escape from bolus that is generated at the transition between the striated and smooth muscles at the level of the aortic knob, okay? We can see if there is a secondary stripping of the reflux barium from the stomach or escape from the bolus, okay, in that area. So these motilities of the esophagus may predispose to reflux esophagitis, because we can prove that the esophagus is unable to clear all the reflux from the stomach. Or in other cases, could be the consequence of severe reflux, because the severe reflux can produce an inflammatory process and damage, okay, of the wall, of the esophageal wall, and this could be the cause of these motilities. What we know is that most of the patients with gastroesophageal reflux, they have an additional motility disorder of the esophagus. After that, we try to evaluate the reflux, okay? So how can we evaluate the reflux? We usually place the patient in the left lateral decubitus in order to pull the contrast that is within the stomach into the gastric fundus. We put the patient in supine position, and after that, in right posterior oblique position, in order that we can see if there is a spontaneous reflux or the reflux is produced with provocative maneuvers, increasing the intra-abdominal pressure, for example, leg rise, cough, Valsalva, or water siphon test, okay? This is a very important test because it increases the sensitivity of detection of gastroesophageal reflux. If the reflux is positive, we also evaluate the severity of the reflux. It means we try to estimate the volume of the reflux. We try to see the reflux to which part of the esophagus goes, if to the lower third, the middle third, the upper third of the esophagus, okay? And especially, we try to see how is the reaction of the esophagus to this reflux. If the esophagus is able to generate secondary contractions, okay, to get rid of the reflux. After that, we try to detect if there are associated findings like hiatal hernia, okay? So we can detect the hiatal hernia in upright position when it's not not reducible, or also in the prone position, okay, with single contrast images. Usually it's more sensitive than the other, okay? And, well, if it's necessary, or it means if we suspect that there are subtle, okay, strictures that we cannot visualize, we request the patient to swallow a barium tablet, and we see, okay, if the tablet stopped or stuck in any specific location. Usually we use a lot when we suspect that there is a Schatzki ring. I will show you later some cases of that. Okay, we are going to evaluate, to discuss now the radiographic findings. Any question? Okay, very funny. Okay, so what is the contribution of radiology to the diagnosis of gastroesophageal reflux? Well, first, detect that there is a gastroesophageal reflux, okay? As I mentioned before, we place the patient in left lateral decubitus, and after that, okay, that the contrast is in the gastric fundus, we turn the patient toward the right side, and we try to see if there is reflux, okay? Usually the table is in horizontal or Trendelenburg position. We try to see if this is spontaneous or with provocative maneuvers, like increasing the abdominal pressure or the siphon test. Okay, we try to estimate the volume of the reflux, but height of the barium, okay, could be minimal, moderate, or severe. And finally, the effectiveness of the esophageal clearance. It means if there is a rapid clearance of the reflux material, barium, okay, or the clearance is slow, or sometimes incomplete, okay? It cannot get rid of the reflux content. Okay, the second one, we try to evaluate the associated findings of the gastroesophageal reflux. Hiatal hernia is probably the most important. Okay, hiatal hernia is the herniation of the upper part of the stomach into the chest through the esophageal hiatus, okay? Probably is due to progressive weakening and laxity of the phrenoesophageal membrane, okay, that fix this area, okay, to the hiatus of the diaphragm, okay. The diagnosis on barium exams is when the junction, the esophagogastric junction, is at least 2 centimeters or more above the diaphragmatic hiatus that is here. So when we see the esophagogastric junction above the diaphragm, more than 2 centimeters, our conclusion is that probably there is a hiatal hernia. Sometimes we can see some faults that arising from the hiatal hernia or from areas above the hiatus of the diaphragm that is here, okay, going through the hiatus of the diaphragm into the stomach and continue within the stomach. So we know that these are gastric faults that goes into the chest. And also, in some cases, there is a loss of the angle of His. So this is the diagnosis of hiatal hernia. One of the contributions of radiology is when there is a diaphragmatic hernia, we easily can differentiate between a sliding herniation or a paraesophageal herniation, something that is important in order to decide the urgency of the surgical procedure. Any question? Okay, so the other contribution of radiology is the diagnosis of esophageal dysmotilities. As I told you before, many patients, they have abnormal esophageal motility. Many patients, most of the patients with gastroesophageal reflux, okay? So I think I told you before this. Okay, how can we make the diagnosis of esophageal dysmotility? Well, we ask the patient to swallow the contrast, and we see that there is a significant delay of the esophageal clearance. This could be to weakened or absent peristalsis, mostly in the mid and lower esophagus. Okay? So this is the diagnosis. In some cases, if we see, for example, tertiary contractions, we can make the differential diagnosis with presbyesophagus. But we will discuss this topic later. So this is the way we evaluate the esophageal motility. We put the patient in the prone position, right anterior oblique position. We ask the patient to swallow 1 sip of contrast, and we evaluate the peristalsis of the esophagus and also the hiatal hernia. The other abnormality we frequently see in patients with chronic gastroesophageal reflux is the diminished opening of the upper esophageal sphincter. We call this protrusion cricopharyngeal bar, okay? It's a filling defect in the posterior wall of the pharyngoesophageal junction that is seen during all stages of swallowing, all stages, always is a narrowing. This is interesting because it's used to the old papers mention achalasia of the cricopharyngeus, but it's not an achalasia. It's due to scarring, okay, and lack of elasticity of the cricopharyngeal muscle as a consequence of chronic gastroesophageal reflux. They think that this contraction, permanent contraction, trying to prevent the reflux to go into the airway, produce some scarring and the fatty infiltration of the sphincter. The treatment is important to detect, includes dilation, botulinum injection, and myotomy on severe cases. And as I mentioned before, one of the complications of this long-standing, okay, cricopharyngeal bar, especially if there is some weakness here, is the Zenker diverticulum. Okay, it's one of the complications. So this is information we have to provide when we evaluate a patient with gastroesophageal reflux. Okay, webs, okay? They are thin mucosal folds, okay, composed of normal epithelium and lamina propria. Could be secondary to chronic injury of the esophageal wall by reflux acid. As you know, there are some syndromes that they have include some webs. But when you see webs, many of those patients, they have gastroesophageal reflux. How we see the webs on the GI exams? They are thin, ultra thin, 2 to 4 millimeter filling defects in the lumen of the GI tract. Okay, it could be unilateral or circumferential. What is important is that they produce, when they are very severe or they obstruct important part of the lumen, they can produce severe dysphasias. So the gastroenterologists appreciate when we mention that there is a web and if there is a significant luminal narrowing. Okay, the other web, or similar to web that we can see, is the web that is located in the esophagogastric junction, okay? That is called the Schatzky ring. Once again, it's a circumferential, very thin ring, okay? And in most of the cases we can see because there is a concomitant hiatal hernia, okay? They are symptomatic when they measure less than 20 milliliters and almost always cause dysphagia when the diameter is less than 30 millimeters. For detection of these rings, sometimes we have to use the barium peel. So we use in those cases. It's probably caused by scarring from reflux esophagitis. What are the other findings when we perform the examination, findings of gastroesophageal reflux, indirect findings? Well, one of the findings is the transverse striations that we call feline esophagus. They are transient. This is a way to differentiate from other, okay, linear abnormalities that you would see later, okay? They are transverse, okay? They are very subtle, okay, 1 or 2 millimeters, and extend from one side of the wall to the other side. So the whole circumference without interruption. They are due to contraction of the longitudinal fiber of the muscularis mucosa, okay, that is irritated by reflux. It's very common. You would see frequently that, okay? And it's associated with gastroesophageal reflux and hiatal hernias. Okay, so these are the findings that they are associated with reflux. Let's see now the radiographic findings associated with reflux esophagitis when there are inflammatory changes. The most common finding is the detection of a granular mucosal pattern, as you see here, usually in the 2 lower thirds of the esophagus. You have multiple examples here. Some of them are subtle and some others are more obvious, okay? Some people call granular appearance or nodular appearance of the distal of the mucosa in the distal third of the esophagus. Usually extend continuously, proximally from the gastroesophageal junction, okay? And the reason for this granular mucosal pattern is mucosal edema and inflammation. Be careful that in some places, I think like here, the endoscopists do not mention that. But the radiologists, we mention that. It's a radiographic sign of mild reflux esophagitis. Sorry. Okay, this is, for example, one example. Okay, same patient last week. I fall in love with these images. Okay, so you can see here, for example, that there is a large hiatal hernia. So it's a short esophagus. You can see a granular mucosal pattern, especially you can see it here, and you can see a feline esophagus. So there is a hiatal hernia, there is a short esophagus, because you can see the hiatal hernia in upright position, the granular mucosal pattern, and the feline esophagus. This is a typical case of reflux esophagitis. The other abnormal findings that could be associated with reflux esophagitis is called inflammatory esophagogastric polyp. Okay, maybe this is the best picture. This is a smooth, ovoid, or club-shaped protuberance in the lower esophagus that continues with a fold that goes into the stomach. Okay, frequently is associated with the hiatal hernia. And the reason for this is inflammatory and granulation tissue due to long-standing lower gastroesophageal reflux. What is important is that the endoscopy, it won't be necessary if the image is typical or characteristic, because it's not a premalignant lesion. Okay, the other finding in the reflux esophagitis, but it's not frequent, mostly we can see when there is a distal obstruction, is the intramural esophageal pseudo diverticula. So you can see here as, okay, tiny, okay, all of them measure almost exactly the same, 1 to 4 millimeters, because they are intramural outpouchings in the esophageal wall. This is very characteristic of what? Yes, sir. Candida esophagitis. Exactly. But in some cases can be seen in reflux esophagitis. Okay, like here. Here you have a stricture due to reflux esophagitis, okay, with sacculation. And you can see here, this is the same patient, the intramural esophageal pseudodiverticula. They are due to when the contrast goes inside the dilated excretory ducts of the deep mucosal glands. Okay? You can see sometimes on CT, it's not frequent, but you can see the wall of the esophagus, and you can see this tiny diverticula inside the wall of the esophagus. So sometimes it's possible to see on CT. Okay. So in some moment, we start to see, with increased the severity of the reflux, the scarring of the lumen of the distal esophagus. So how can we see that? Well, first of all, we can see that there is an irregular mucosal pattern in the distal esophagus, usually associated with hiatal hernia. We can see, like in this case, that there is a deposit of contrast radiating or concentric folds. Okay, you can see here the concentric folds going to one point. Okay, here also you can see some transverse folds going to this area when probably you suspect there is an erosion or ulceration. And finally, a radiographic finding that is called the step ladder, okay, appearance, where you can see pooling of barium between the folds, okay, that they do not extend from one wall to the other, just goes maybe halfway of the lumen, okay? So these are characteristic findings of scarring of the esophageal wall due to chronic gastroesophageal reflux. The Z line, that is the transition between the esophageal and gastric mucosa, can be seen, especially when the patient has a hiatal hernia, okay, as just a linear or zigzag abnormality in this area. Usually it's associated with reflux and hiatal hernia. You can recognize here what's feline. Okay. Okay, in some cases, we can see ulcerations, okay, erosions or ulcerations. If you can see on face, you can see a deposit of contrast, sometimes surrounded by a radiolucent halo, that is the edema surrounding the ulceration, like here, okay? And in some other cases, you can see in the lateral view, single and double contrast. So you can see erosions or ulcerations. Usually, most of the cases is unique. There are no multiple, okay? I'm going to... And due to the scarring of the esophageal mucosa, we can see sacculations, the same mechanism as Crohn's disease. So you see one asymmetric involvement with, how to say, a stricture, and this produces a sacculation on the opposite wall. So for example, if you suspect that there is here an ulceration, so this is a sacculation, okay, produced by the ulceration in the opposite wall. Same as here. This is a sacculation, and you can see the converging folds going to the other wall. Same as this one and this, okay? So there are multiple outpouchings. If you have a Crohn's disease of the esophagus, I never see one in my life, you have a differential diagnosis because this is an eccentric scarring. So pseudo-diverticula and sacculations should be differentiated from ulcerations. How can you differentiate between both? Well, usually sacculation, they change a little bit during the examination. And second one, they do not have converging folds to the deposit of contrast, goes into the surrounding. When you have an ulceration and you see converging folds, all the folds go to the ulceration, not to any other place. Strictures. Okay, finally, more severe cases, they have short peptic strictures. These are the most common. Between 10 and 20% of the patients with chronic reflux esophagitis develop peptic strictures, okay, just due to the circumferential scarring, okay? So you can see a narrowing of the lumen, okay? You can see here a hiatal hernia. You can suspect that this is a very short esophagus, okay? And you can see here in single and double contrast. If you are not sure with double contrast, use single contrast, especially with a patient in prone position with good distension, to be sure if there is or not a peptic stricture. Okay, and most of the peptic strictures are associated with a short esophagus. So we can see when we perform the examination that the esophagogastric junction is well above the diaphragm, this case or this other case. Very rarely, you can have large strictures due to reflux esophagitis. This is uncommon. When you see a large peptic stricture, okay, and you are not sure about if this is a reflux esophagitis, you can mention some differential diagnosis, maybe like severe acid reflux, like in Zollinger-Ellison syndrome, caustic esophagitis, long-standing NG tube, bile reflux, or alkaline reflux in patients after gastric surgery. How can we detect the subtle strictures and we evaluate the severity of the stricture? Well, as I mentioned before, we use the barium pills. So we asked this patient that we suspect was some stricture in this area. We are not sure how severe was the stricture. If this stricture could be the cause of the symptoms of the patient. So we asked the patient to swallow the pill, and the pill stuck there. So it was significant. Okay? And maybe this was one of the reasons of the patient's dysphagia. The same happened with the pill in the cricopharyngeal junction. We asked the patient to swallow the pill, and the pill stayed there for a long time. This is a different patient. The patient had to leave the radiographic table with this gift. We had to wait until the pill dissolved, because during the examination, we request the patient to swallow water, and the pill was there. So it means the cricopharyngeal bar was very severe at that time. Okay, So as you well know, the replacement of the normal stratified squamous epithelium of the esophagus by the gastric epithelium produce something that is called the Barrett esophagus. Okay, the prevalence is about 10% in patients with reflux esophagitis. How can we detect Barrett esophagus with radiology? First of all, it's not very reliable radiology. Also endoscopy for detection of Barrett esophagus. We have to perform biopsy. But we can suspect in some cases that there is a patient with Barrett esophagus. How? When we detect a high, luminal stricture or ulceration. Okay, when we see this stricture far from the esophagogastric junction, or this other case here, we can suspect that this is due to a Barrett esophagus. All these cases need biopsy. The other abnormality that is associated is the granular mucosal pattern, usually seen distal to the stricture. So this is when we suspect that there is a Barrett esophagus. Of course, the patient had always hiatal hernia and gastroesophageal reflux, because you would see Barrett esophagus only on severe cases. Okay, just a few words of differential diagnosis. Maybe it's too much information, but it's necessary, I think. Okay, every time you perform an upper GI on a patient that you suspect gastroesophageal reflux, just evaluate the gastric empty to be sure that there is no gastric outlet obstruction. Like this case, you're going to see the contrast going into the duodenum. The stomach is dilated, okay? And you can see that a consequence of the dilation of the stomach, there is a gastroesophageal reflux. So the real problem is not here. The real problem is there. Probably when you fix the gastric outlet obstruction, this is going to improve. The other problem is to make the differential diagnosis of esophageal motility disorders. As I mentioned before, the diagnosis of esophageal motility disorders in gastroesophageal reflux disease is a weak or absent primary wave. When you see tertiary contractions, it means non-propulsive contraction. One of the differential diagnoses is the presbyesophagus. When you see that additionally to tertiary contractions, there is an insufficient openness of the lower esophageal sphincter, could be vigorous achalasia. But probably the most difficult differential diagnosis is scleroderma, because you have a hypomotility of the two lower thirds of the esophagus and an incontinence of the lower esophageal sphincter. It's very difficult to make the differential diagnosis, okay? In some cases, when you have patients with scleroderma, due to the long-standing gastroesophageal reflux, you can have strictures due to that cause. They are really peptic strictures, but the cause is the scleroderma and not the gastroesophageal reflux. And finally, one of the complications of Barrett esophagus is the adenocarcinoma. These are 3 different patients with adenocarcinoma. In most of the cases, they involve the lower third of the esophagus, and they have some differences with the peptic strictures because they have filling defects. Every time you see filling defects within the stricture, you have to prove that this is not a cancer until proved otherwise. So you almost always suspect that there is a tumor when you see filling defects. It's extremely rare to see an inflammatory stricture with filling defects due to inflammatory changes. Okay. Well, this is for also differential diagnosis. This is a case I showed you last Tuesday, I think, where a large stricture due to caustic esophagitis. Okay, so this is probably the last slide. What are the indications of the surgery, okay, in patients with gastroesophageal reflux? We have to know the indications because probably we will have to perform the pre-operative examination. So persistent or recurrent symptoms despite medical therapy, okay, Barrett esophagus with ulceration, stricture, or mild or dysplasia, okay? Benign strictures due to inability to treat them endoscopically with dilation or frequent recurrence of the stricture, recurrent pulmonary manifestation like aspiration, pneumonia, asthma, or inability to tolerate the medication, okay? So in conclusion, gastroesophageal reflux is a common illness in America. It means the topic is important because it's frequent. We would see almost every day patients with gastroesophageal reflux symptoms, okay? We provide some information. First, we can prove that the symptoms are due to gastroesophageal reflux, and we can estimate the severity of the reflux. We can make the diagnosis of anatomic abnormalities that they are associated with reflux. For example, hiatal hernia, short esophagus, okay? The Chasky ring, okay? We can evaluate esophageal motility disorders that they are associated. We can evaluate the consequence of the reflux, the esophagitis, strictures, Barrett esophagus, and adenocarcinoma. And additionally, we can provide information about the swallowing abnormalities due to chronic gastroesophageal reflux. Questions? Yes, please.
That picture with the cricopharyngeal bar, was that a cricopharyngeal jet?
Not on this case, but not on, I don't know where is. Yeah, yes, sir, sorry, yes. This is a jet sign, yes. It means that the stricture is significant, yes, sir.
Which was image for ulceration?
Sorry?
Images for ulceration.
Yes. This is one of them. On face, and okay, this is a lateral view of the ulceration. Usually they are associated. You can see, for example, here that there is a stricture, same as here and same as there. This is a hiatal hernia. So it's not an isolated ulceration surrounded by normal mucosa. No, everything is abnormal. The ulceration is one of the findings. This is different than other ulcerations or erosions. For example, if you have infection, esophagitis, in some cases you can see the ulceration, but it's surrounded by normal mucosa. In this case, it's almost always surrounded by granular mucosal pattern or strictures, hiatal hernia, and you can see the reflux. You cannot get esophageal ulceration without a significant reflux when you perform the exam. It's not an option.
Is the convergent folds here? Because I saw the next slide shows the convergent folds.
Yes, yes. So, well, in this case, it's different. These are not ulcerations. They are saculations. So in many cases, you can see the folds, and the folds do not converge to this point. There are no converging folds here. The folds go to other areas, but not to this area. And sorry? No, this is pouching. This is pseudo diverticula. Okay, how do I know? Because first, there are no converging folds. Okay, second one, if you put a line here, it doesn't go beyond the wall of the esophagus. You see, it's inside the wall. Okay, so it's a sacculation. This is due to retraction of these and these two areas. So there are two areas of retraction, contraction, and this is just an area that was not affected by the contraction. So how come you make the differential diagnosis? Well, first of all, this is too large to be an ulceration. But you won't see that the converging folds goes to this area. If this is an ulceration, it should be projected outside the wall, like here. This is the wall, and this is projected outside. It's projected outside. And three, if you perform multiple images, you would see that the circulations change, something that do not happen with the ulceration due to the degree of fibrosis. Ulcerations, they have high fibrotic content, and the circulations, they do not have fibrotic content. So when you perform multiple images, changing the position of the patient and the distension, you would see that one of them do not change, and the other one will have some slight changes. Questions? Comments? Okay, well, thank you.